for everyone joining. We're going to start the session in a few minutes. Okay, so bear with us. We'll start our session soon. Welcome, everyone. I think we can wait for a minute or so until some of the other people participating can join. So we're going to be starting at 2 minutes past the time. If that's okay, just to allow people from other locations to join the session. we can start the session now. Thank you. Well, I would like to welcome everyone to this session with Rivka Hagen, Northlead Clinics. I would like to start our session by acknowledging the traditional custodians. I acknowledge the traditional custodians of this land, the Turrbal and Jagera people of Brisbane, the Gubbi Gubbi people of Caboolture and Bribie Island, the Waka Waka people of Kilcoy, and the Ningi Ningi people of Redcliffe. I pay my respects to elders past, present, and future, for they hold the memories, the traditions, the culture, and hopes of Aboriginal and Torres Strait Islanders, Australia. So thank you everyone for joining the session. This is a lunch and learn session. If you have your lunch with you, please feel free to eat with us. Please have your cameras open. You're more than welcome to join the session, ask questions. So please interact as much as possible with Rivka. We have some housekeeping rules. So we're going to be sending a survey after this webinar closes. Hopefully will pop up. If the survey doesn't pop up, we'll send it to you later. Please help us answer this survey, as this is one of the ways we can keep track of the type of opportunities that you would like to have for training, and also different topics that we would like to see. And if the session was up to standard or not, so please help us by filling up this survey. The session will be recorded and will be sent out to those people who register for the session. And as I mentioned, please interact as much as possible. We're all here to learn. So without further ado, I would like to introduce you to your speaker today, Rivka Hagen. She needs no introduction, so I'll leave it to her. Welcome, Rivka, and thank you for joining us today in this session and for facilitating this session.
Thank you so much, Julio, for again inviting me to come and have a bit of a natter with your cohort at Brisbane North PHN. I'd also like to acknowledge the traditional custodians of the lands on which we're meeting. I am located in Djadja Wurrung country in central Victoria, so slightly different location from where you are located. No doubt a whole lot cooler and not nearly as nice as what you've got going there. Welcome everyone. As Julio said, I'd love for everyone, if at all possible, to keep your cameras on, and if you like, open up your microphones if there's not too much noise in your background, just so that rather than me kind of yapping at you for an hour, we can start to have more of a conversation. It can be a little bit more interactive. This is absolutely an informal session, really designed for you guys to share some of your wisdom and knowledge as well. So don't feel shy or coy with interrupting me. Just come and tell me what's on your mind. If you're a bit concerned, you can always use the little sort of hands up, or just indicate to me that you'd like to come and join the conversation. So let's get started. We are talking today about the thinking and the process of developing your nurse-led or team-based services. So today's session is designed to take you on a bit of a journey around the thinking and ideation processes that you might want to undertake as you are contemplating introducing newer, innovative services within your practice, with the real focus of them not so much being led by the GPs, but really sort of being led throughout the team, and then the nuance and thinking that you need to apply in that space. So you can see on your screen here, there is a very colourful mind map, and Julio will send through a copy of this. It's a PDF, and I think it's in A3 format. So if this appeals to you, you can certainly print that out, and it will give you a really good visual to just remind you of where are the steps that we're up to, have we missed anything. It's really designed to just be that sort of cognitive reminder of all the things that you need to contemplate when you are developing new services as well. And again, I do want to reiterate, as what Julio has said as well, is that this is a lunch and learn. So if you need to eat, if you need to drink, absolutely fine. That is exactly what we're expecting you to do. It will add to the informality of today's session. So feel absolutely free to jump ahead. Very happy with that. All right, so let's get going. And look, I guess before I get going, let's open up the floor a little bit. And, I want to put a little challenge out to you to ask you, what have been your sort of team-based services? What have you developed recently? Have you already started? Are you already well developed with team-based services? What are you thinking about doing? And kind of what's your big question coming into today's session as well? So would anyone like to maybe just give me a little bit of a heads up on what you're thinking and what you're doing? There's going to be someone who's got some thoughts, who's going to open up their microphone, because I'm going to sit here and wait until you talk to me. Suzanne, I can see you smiling. What are you thinking? What's on your mind? And I'm not wanting to, like, put you on the spot or anything.
No, you're right.
Tell me what you're thinking.
Can you hear me?
Yes, absolutely.
Yeah. I guess we're looking at starting up an osteoporosis program, nurse-led osteoporosis program. So we're just kind of in the early stages of that. So I guess that's what we're looking for. We have done a couple of other programs for healthy weight and healthy aging and things like that. So yeah, I just wanted to learn about those.
Okay, so I guess what we hear a lot of is that there are still many practices kind of stuck in the sort of traditional diabetes clinic. There's been just a lot of focus on that over many years already. And I love the idea that you're starting to broaden out your thinking in terms of doing other innovative work in terms of osteoporosis, and other ideas that you might bring to the table. So I think that's great. Does anybody else have any other types of services, nurse-led services, team-based services that you're thinking about? Gee, you got a shy bunch here, don't you, Julio? Rebecca,
a little bit, it seems so.
Do you want to come and join the conversation at all?
Me, I'm here, yeah. So I'm only here for information as well. So we are just currently looking at a few different areas. I think we're maybe broaching to like sort of weight management, that sort of side of things, because that feeds into a lot of chronic diseases. Our nurses currently don't do care planning. I know that's very unusual. So we're also looking at that scope of things as well, seeing as changes have been pushed back now. So for us, that's what we're looking at the moment.
Good stuff. Good to hear. All right, we've kind of broken the ice a little bit, so that's really good. Let's get into the mind map then and the process of thinking whilst you're planning your services. So I guess it all starts with an idea, doesn't it? And that's kind of what I was prompting you about just before. So, we know that from the chronic disease management point of view, I guess the language is changing a little bit, and it will as the changes to Medicare will roll out over, the next year or so into the middle of next year. The language around chronic disease is changing a little bit from chronic disease to chronic condition management. So a slight sort of change in terminology that will be coming up. But the sorts of things that we're talking about there, diabetes, kidney health, renal function, care planning in general, which kind of speaks to what you were referring to, Rebecca. Asthma spirometry clinics, that's probably fallen away a little bit since the changes to the Medicare item numbers. That's kind of made that a little bit clunkier. However, that's not to say that you can't focus on an idea. If you've got a lot of asthma patients within your clinic, you'll want to be thinking about, well, what can we do for this cohort of patients if you are seeing a gap in the market and a need within your community that requires filling. COPD, cardiovascular disease, heart health checks, and as already mentioned, things like osteoporosis. And of course, the list is really quite endless. I've got a couple more examples for you coming up as well. With Indigenous health, we know that we've got the Aboriginal Torres Strait Islander health assessments, the item 715, and the care planning services that sit in and around that. They tend to be kind of custom made to work well with a nurse-led type of approach. Because of the kinds of work involved in data collection and recording of information. So a lot of practices are developing sort of nurse-led Aboriginal and Torres Strait Islander health checks. Some of the other ideas that you might want to think about is as women's health. We're hearing a lot about menopause clinics coming up, but also, again, just women's wellness clinics as well. Over the years, again, cervical screening was a big thing, again, because there's now been changes to the way that that's done. That's kind of falling off a little bit. So it's a really fluid environment. What is a good opportunity at one stage might end up, really sort of, being obsolete down the track. And cervical screening would be one of those with the onset of self-collect and the like. Other ideas: refugee support clinics, immunisation clinics, youth health clinics, liver health, mental health, LGBTQI support services, wound care clinics, leg ulcers, Dopplers, acute wounds, etc. And the list goes on. Julio.
Yes, we have a question in the chat by Annie.
Oh, great. Yes, you'll need to keep an eye on that for me.
Yeah, so she's saying, why not a sexual health clinic? And she's sorry she doesn't have a microphone.
Yep. Absolutely. I think sexual health clinic is a really great idea. I guess, what I was referring to just before in terms of the cervical screening specific idea that, because of the changes to the testing regime there, that probably a clinic in and around that possibly isn't quite as worthwhile now as what it was in years gone by. But absolutely, sexual health clinic is a great idea, and there are many services that run sexual health clinics, of course, and many of them are nurse-led as well. All of this, the ideation around this, it's as broad and wide as what the service types are that are out there. So the point of the ideation and the sorts of clinics you might think about is not that this is any kind of definitive list, because it isn't. It's about thinking, who are we? What is the client cohort that we service? What does our community need? Where are there gaps that require filling, where our nursing services could well sort of feed into that? So that's a really individual activity that you need to do with your team, with your practice, so that you come up with some really good novel ideas of what can be done there. So absolutely, this list is not exclusive. Were there any other questions, Julio?
No, to this moment, just that one.
Yeah, great. Thank you. All right, so I guess you would start then with gathering some information. If you've got a bit of an idea that you go, oh, I wonder whether we could do something in any area of interest, it really starts with data collection and really testing your hypothesis of whether your idea is going to have legs within the context of your practice and your community. So you might use any of the data extraction tools that are available to you, whether it's through your practice software or other data extraction tools such as PenCat or Polar or Primary Sense, or even, the likes of Cubico. You could definitely gather data from all of those sources to get a better sense of who's our clientele in this. What cohort are we really looking at? What would be the patient numbers that could be interested in our service? So that could be around, analysing clinical conditions. It could be around ages. It could be around gender. It could be around conditions. So there is a lot of data that you will want to lean into to start to give your idea a bit more legs and to start to build the rationale for developing a service. Julio.
Yes, and I just wanted to add that if you wanted to have someone to work with you on your data, that's what our engagement officers can help you with. So you can ask practice support, and we will support you through this process of understanding your data and how to analyze the data and use it for this type of activities.
Yeah, I love that. Of course, that PHN is there to help you with all of that data interrogation, because they are just as invested in this whole process as what you are as well. So in terms of that initial data scrutiny, that will really tell you a little bit more whether the clinical need has been established or not. And if it hasn't, well, then you might want to redefine your idea or dig a little bit deeper to see, where is it that we're going to play. If the data supports your hypothesis, which of course in many cases it will, because you're already working there and you already innately know the operating environment of your practice, then it kind of gives you the go ahead to really start doing some more solid planning along the way. At that early stage, though, it's a really good idea to start thinking about any of the potential or actual risks that could be realized as you embark on this new service delivery. So there could be some risks around finance. If you don't map this out properly, then you may end up with a financially unviable service. That's a big risk, and that is one that you want to spend a lot of focus on remediating. There can also be clinical risks associated with developing a new service if it's not well implemented or patient outcomes are not realised, or any staff member is acting outside of their scope of expertise. It brings in that notion of risks, so you need to be really aware of that as well. Out of those risks really is sort of that secondary risk that if the planning and the implementation isn't done really strongly, then it could have a reputational impact on your service as well. You don't want that to happen, right? So you want to do your planning really well from the outset to give you the best chance of success, so that you're not going to hit any of those reputation hits in terms of the service really not being valued or not understood by the patient, or that they just didn't really have a good experience with the way that service is being rolled out. Of course, think about compliance, and the big one there is adherence to Medicare benefits schedule compliance requirements. Make sure that where you're tapping into MBS items, you do that in a compliant fashion. And of course, we're referring to things like care planning, team care arrangements, health assessments, and any of the other MBS items that come along with that as well. So you need to really cast your eye in that direction too. And any other risks. So pertinent to your idea and your type of service delivery, there could be other risks that you just want to be across. You want to be aware of them so that you can address them and mitigate them as best as possible. So once you've done that, you really want to socialize the idea with your practice, don't you? Often, as far as practice managers are concerned, there's a lot of ideas sort of bubbling around your head, and it may not be well understood by the broader team. So the idea of really communicating within your team about what those ideas are, the identified risks, and why this might be a good idea is a very key part of ensuring its success down the track. So you want to ensure that the options are communicated well. What you also want to do is, as you start to develop the model, is test it with your team around you. What have we missed? Is this the right way to go? Do we need to be thinking about anything else? And what else? And what else? That, existential question around sort of, the coaching of how are we going to get the best out of this? You want feedback from the team and ensure that you've captured everyone's ideas. It's the best way, of course, to get the buy-in for the successful rollout, because it's going to incorporate your entire team there. Then we want to develop the model further. So you've socialized it, you've now gotten the feedback from the team in terms of, here is the idea, here is some of the pre-planning that we are doing. We are going to possibly dig in deeper to our data analysis. We might need to then consider, do we need to cleanse our data? Is anything of our data requiring updating, remediation and cleaning before we really sort of start to lock in our idea further? Again, just coming back to that idea of, the clinical need. Are we on track? If we are doing this, what are we not doing? So is our new service going to come at the expense of another service delivery? All those things really need to be captured very closely. And of course, that recap with the team of the risk analysis and then the mitigation strategies that you're going to put around that. Now, this is probably the really big one. We won't spend too much time on this, but the financial impact of the service that you're looking to develop is absolutely of prime importance, because not only does it need to be financially viable, you need to ensure that you've got some dollars left over at the end of the day in order to sustain the service and ensure that it's going to be able to be delivered over a longer period of time. So there is a budget planning exercise that you absolutely need to undertake. In the next slide, I will give you a link, and Julio will also send you the link to an actual budget planner. It's a resource, it's a tool that kind of sits along the side of this sort of ideation program to help you to really drill down on the numbers. Now, I'm not going to drill down too much into it today because that's pretty much an hour's webinar by itself. So I'm not going to do that. However, you can get access to the budget planner at no cost. Just download that. Along with that is an explainer video as well. So it won't be live like what this is, but you will be able to get an explainer of how to use the resource. It's an Excel spreadsheet, and there is some complexity to it. So I'd really encourage you to have a look at that. So what it will allow you to do is exactly what it shows here on this mind map. It's going to consider all of the income sources that are going to be associated with your service, as well as all of the expenditure items, so that you have a sense of comfort around where the budget is going to land as far as your new service is concerned. So it will allow you to incorporate any Medicare items that you might be using for this particular clinic. It might be looking at gap fees for GPs. It could be looking at gap fees or totally private fees for nurses as well. It will also allow you to incorporate any QIPP funding that you get that you want to factor in to the budget planning for this exercise. Workforce incentive program as well. Of course, we for the accredited practices, we also get the nursing workforce incentive payment. You might want to allocate a little bit of that to beef up the budget planning for this as well. And really any other sources of revenue that you might think of. And on the expenditure side, we look at, well, out of the service that we are developing, are GPs involved at any stage? In many cases, the answer to that will be yes. And where, especially, of course, where the MBS items are involved, the GP will be retaining a percentage of the fees that are generated. So you need to factor that in. Then the staffing costs, including nursing and administrative staff, and perhaps even a little bit of practice management as well, and any other costs. It might be room rental, it might be utilities, it could be consumables, it could be setup fees, it could be any number of other expenditure items that you need to map out when you're developing a new service. Now, what I also want to just kind of lean into is just, this little pocket here in terms of gap fees for nurses. In my travels, I haven't seen too many practices become terribly innovative in terms of understanding the expertise of their nursing staff and being bold enough to introduce private fees that have no MBS item number attached to them for innovative service delivery. And so again, depending on what you're trying to put together, that may or may not be applicable to you. But if you are really thinking outside the box, I'm going to encourage you to also think outside of the Medicare benefits schedule box and say, don't be limited to what Medicare allows for or specifies when you're ideating around some of these service provisions. What I want to maybe just put a little bit of flesh around for you is just an example of where I've implemented this myself in my practice management role. So this was a little while ago. I've been out of general practice for a little while now. However, we had a nurse within our team. It was a large GP practice, 21, 22 GPs, thereabouts, multidisciplinary. One of our nurses was a credentialed cervical screening nurse. And when I came on board, she said, hey, Ruth, I would love to develop a cervical screening clinic, but not just that, I want to turn that into a women's wellness service. And I want to run this at nighttime because I think the women who would really appreciate that service are probably working women who can't get in to see their GP during the day. And I want to give it a very different flavour to what a sort of traditional GP type of service would look like, you know, the sort of stock standard type of service. And I kind of went, oh, I'm, you know, really interested in this. And we went through this exercise of kind of mapping this out. And, you know, she was quite adamant that being credentialed in this area meant that she didn't necessarily need a GP to be sitting side by side to run that service. It could happen if there is an escalation of service need. But for routine services, I guess, she felt that she would be able to manage that by herself and that she wanted to explore the idea of just running that as a private service. And I kind of went, I love it already. So we kind of worked out, well, what sort of fee do we need to set if our nurse is going to work evenings, you know, using a clinical consulting space. We need to ensure, of course, that there is reception available, all those sorts of things. You know, what would that look like? And already back in those days, and I'm talking about a decade ago, so it's a long time ago, we came up with a fee of around about $40 at that time. So still reasonably conservative, but not nothing. It was a real sort of, you know, marker of willingness to say, I've got something that I think I can offer that I think has value. And, you know, we tested small, we started really small, and it was an absolutely roaring success. And in fact, the feedback that we got from the evaluation of that was that the women that tapped into that service absolutely loved it. You know, the grapevine kind of went around and the service became really well known. And it didn't take long at all for waiting lists to start on her unique service delivery. So that's my sort of little anecdote to say we ran that outside of the Medicare benefit schedule framework. Occasionally it intersected with a GP because of the need to escalate, but essentially it was a private nurse-led service and our patients absolutely loved it. So, you know, I guess take of that what you will, but yeah, just a challenge to say not just MBS types of services. Okay, so just coming back to the budget planning tool that I was telling you about, don't get too concerned about the busyness of what you see on the slide. If you want to and you can, feel free to zap the QR code and you'll get sort of straight into the area where you're able to download this tool so that you can work through, like I said, the income, the expenditure side of things, and start to map out the what's in it for me, not just for the practice to ensure its viability, but also the what's in it for me from the perspective of the practitioners who may be involved in this as well. And so the tool was kind of expanded out further in more recent times to kind of put a bit of a spotlight on the idea that where nurses undertake a chunk of work, that it saves time for doctors who would otherwise have to undertake that chunk of work. And we try to map out a little bit of what are the time savings because we now have a nurse undertaking a good chunk of that work. And the clean example of that is in terms of care planning, GP management plans and team care arrangements. And then how does that translate to additional work opportunity for the GP that otherwise wouldn't exist? So the what's in it for me for the GP and the what's in it for me for the practice is also explained there. Julio. I can't hear you, Julio.
Apologies for that. So I bring another question
Sure.
from the chat. This is a question from Adrian, and he's asking how long was the consultation time for when it was the $40 for the registered nurse?
Yeah, it's a great question. At that time, I think it was about half an hour. It is a while ago, so it might have been a bit longer than that, but it was sort of quite a comprehensive, um, I guess, journey. So the way that the service was rolled out, it touched on many areas, including overall health and wellness, boob check if that was relevant, health and lifestyle discussions, which were, sort of very effective from that nursing perspective as well. Sort of really going into sort of the health coaching as well. Often the sorts of things too that were picked up in that service were issues around family violence, which won't necessarily come out in more traditional, sort of quicker consultations. That the fact that this was a slower pace of service delivery, that opened up the opportunity for other issues to come to the table that otherwise might not be disclosed. So they were certainly not short appointments, they were more extended, and that was kind of the whole idea, that we want to be doing more, for these women. So yeah, it looked something like that. Adrian, did that answer your question? And again, feel free to just open up your microphone, eh? Turn on your camera. Oh, you've got your camera on, but your mic is off. Did that answer your question, Adrian?
Yeah, that was very helpful. Thank you.
Okay, excellent. I think you're on two sound systems, so there's a little bit of an echo happening there, but that's okay. So that's the budget planner. What I would suggest is that when you do undertake the activity of budget planning, that you kind of involve the key stakeholders who are involved in delivering the service. So include the practice manager, include the nurse or other team members that are going to be really integral to this, because it is that ideation around, well, okay, what are we going to earn? What is it going to cost us? And is it balanced? Is it going to work for us? And what do we need to do if it doesn't land in success straight away? The budget planner is great because it will allow you to play with the numbers, and it will allow you to do that what if scenario planning. So what I would say with this too, and you will see this in the explainer video if you do access that, is that the viability component very often rests with the percentage distribution or withholding by the GP for their involvement in any of these services. So that percentage is usually the biggest expenditure item associated with the service, and that can often be the decider on whether the service is actually viable or not from the practice perspective. You'll get some visibility on this, and the tool will allow you to map that out and show it very clearly for the purpose of bringing it back to the team to say, I think we've got something solid happening now, or this is what we would need to do in order for this to actually work in the longer term. So I'll be very curious to hear how you go with your budget planning. This tool was actually also developed for APNA, so a version of this is also available from the APNA website, which is kept up to date as well. So either way, you can get it from me or you can get it through APNA as well, which is fine. Okay, so we've done the budget planning and we are satisfied with where the numbers are landing. So we then need to consider the promotion and the marketing of the service out to your patients. How are they going to know that you've got your new service available, and what's that going to look like? This is a pretty big piece of work, and it deserves to be done really well if you want to have a successful launch and give the new service the flavor that you want to put around it. This is often done a little bit on the fly, a little bit on the hop, but I don't want you to forget about this. So you'll want to ensure that you can contact your patients, of course, with consent, and think about how you might do that. Who's your demographic? Who's your target market? Are you going to send a text message, an SMS? Are you going to email? Are you going to send a letter? I don't think you would do that because that's a painful way to do any kind of promotion. Might you do a telephone call? Is it a very personalized invitation? That could be a way to go. Are you going to promote this on your website? What are the words and how are you going to tell and sell the story and the service to your patients? Might you include some blog posts? Are you going to put that on social media? Do you have social media? How's that going to get propagated? What are your communication strategies going to be with your patients in terms of outlining why this cohort of patient wants to come and tap into this service? What's the benefit? The what's in it for me, for the patients, is the most critical aspect of this, because if your patients don't understand what you're doing, then they're just not going to be all that engaged. I guess, again, a really clean example around this is care planning. We know at the moment how complex care planning is from a compliance point of view, as far as Medicare is concerned. And trying to sell that as a valuable service to patients can be really tricky. They need to come in, they need to have their care plan done, they need to come in for reviews, they need to get referred out. How do you tell a compelling story around why that's important to them? So think, of course, about the patient as being just so central to this entire rollout of a new service. If it isn't going to be valuable to them, you are not likely to have a successful program. So you want to communicate those health and well-being outcomes. It might be around early detection. It might be about the comprehensiveness about the service. It might be just doing things differently, just like what I explained with our nurse-led women's wellness clinic. It's about doing things differently. You're going to get something different from what you've traditionally gotten from our practice. Be really specific. Do some attention-grabbing promotion. You might want to, think about, of course, the language that you use, the tone of the communication out, how are patients going to feel about their desire to tap into this service. And of course, be very clear about the costs and the processes involved. Avoiding jargon and medical language is really important in any sort of service promotion to patients, because we know that if you make it too complicated, too complex, many patients are simply not going to understand what you are communicating with them. So the simplification of language is really important. There are some tools available that will help you to review the material that you've produced and actually give it a readability check to ensure that you've kind of nailed that really, really well. Plain language, but of course make it look inviting and enticing. So that's a little bit about the marketing and promotion of the service. Then, of course, we need to think about training, education, and resources. For your new service, it may need for your staff to receive some further training, upskilling, in order to really be able to deliver the service well. So think about, resources like APNA, the Primary Care Nurses Association, RACGP also have fantastic resources. It could be in-house training that you need to beef up. It might be all of team training. It could be one-on-one. You could be doing some lunchtime sessions, not dissimilar to what we've got happening here. You could also be required to develop some written support material for patient education and engagement as well. So the support materials, of course, think about policies, procedures, workflows, cheat sheets, for the sake of communicating with your broader team what you're doing, how you're doing it, what the patient flow is going to look like, the clinic mapping, what's the journey going to look like from promotion to intake to service delivery to evaluation. What are each of those steps going to look like from the patient's perspective? Really importantly too, think about weaving patient feedback into that entire process. Because if we are developing services that have the patient at the heart of it, then their experience with this is hugely valuable and absolutely critical for you to understand whether you've hit the mark or whether small tweaks might improve the experience. And I would really encourage you to do that for any of your service delivery, but especially when you're developing new services, to weave patient feedback and evaluation into the entire model of care. Think about QR codes, right? So simple to do. It might be part of the workflow whereby, as the last element of the service delivery, the nurse or whoever is sort of the last contact point will ask the patient, we'd love your feedback on what you've just experienced in this service. Either here's a form or here's a QR code. Please give us some quick, simple, you're not talking about a 20-page evaluation, but you really want to know what went well, what didn't go so well, what was the best bit, and what suggestions have you got for us going forward. And, if patients loved it, they will love that you've asked them what they thought of your service. And of course, if they come up with real nuggets of ideas for improvements, you can't get better feedback and service improvement than to tap into that. So that's pretty important. In terms of the clinical training and resources, of course, your PHN is really critical to that. But other industry associations as well, again, depending on what your service is going to look like. Could it be Diabetes Australia, Cancer Council, Heart Foundation? Again, this is just a snippet of all the industry associations who are out there who can support the work that you are doing within your newly developed service. So weave their resources into what you're doing as well. And finally, don't forget the RACGP standards for general practices. It says ACPAL there. It's not just ACPAL, it's also QPA and a couple of other accrediting agencies who will attest or who will assess to those standards. But make sure that you are compliant with accreditation standards. Of course, this whole process from an accreditation point of view is a fantastic quality improvement activity. So capturing just this entire journey in the way that you are working it and planning it is in and of itself a quality improvement activity. So note that down in your quality register, your quality improvement register, and put that in front of the surveyors come accreditation time as well. And then we get to the implementation phase, of course. We need to think about the practicalities around appointment schedules, appointment lengths, how's that going to work, associated GP appointments and coordination, if that's relevant to the service that you are developing. What would a rebooking process look like? What are the implications for staff rostering? Do you need additional staff to be able to manage this new service? In terms of attending the patients, ensuring that you've received adequate consent processes for what you are doing, documentation of the service, that's really no different to what it would be for anything else. Any kind of service delivery needs adequacy of health records and the like. Do you need to set up reminders, recalls as part of this new service? That needs planning and implementation as well. The provision of feedback forms, are we assured that every patient is aware that there is a feedback mechanism and that it's made sort of easy and accessible? Very importantly, the completion of billing. This is, I guess I'm sort of having a bit of a laugh, but how often does that happen? That we are delivering one mighty service only to find that the patient has walked out and we've not captured the billing for that service. How are you going to stop that from happening? How are you going to ensure that you're going to get the revenue that you need for the service that you are providing? And communication with the care team as required. You might also need to think about your consumables and patient resources that you need to have ready and keep stocked. Who's in charge of that? Who will guide and coordinate that? And then sort of finally, just start with a small number, right? If you're thinking about that sort of whole QI process, we want to test our idea and our model with a limited number first. And it could be just with one patient. It might be that you've developed some workflows and you want to test that out. You might get one patient in as the guinea pig and run your program and see what worked, what didn't work. Once you've develops a little bit of confidence there, you might just expand it out a little bit and do a couple of patients. You might then sort of develop it further out to a session or a full-fledged service, but don't go in boots and all right from day one to find that you've got some significant gaps that still need to be filled. It kind of comes back to the risk management as well, that you've got early opportunities to work out, hang on a second, we haven't thought enough about an aspect of the service that we're delivering, but starting small means you can remediate it before you roll it out. If, of course, you've, all of a sudden got 20, 30, 40 patients booked in for a service, and you don't sort of realize things aren't quite right until you're well into it, you're going to take that reputation hit if it's obvious to patients that something isn't quite right. So it's about risk management, tweaking, fail fast. So work out quickly which bits aren't working, and I guess solidify the bits that are working well. So start small and then develop it out further. And then you're running along, you've got your service up and running, which is really, really great. You do need to, at some point, pause to review how are things going. So no set and forget as far as all this is concerned. We want to get some feedback from the service providers and, of course, the nurses or others who are actually delivering this service. You want to evaluate the feedback that you've received from patients. You want to also ensure that the budget planning that you've undertaken is reasonably accurate. Have we actually achieved from a budget perspective what we expected? If so, great. If we did better, how did that happen and why did that happen? That's a good thing. And on the converse, if the financial results have been disappointing, why is that? What is it about our modelling that hasn't rung true? Do we need to go back and tweak that and amend that to ensure that we're going to be okay going forward? Review the clinical data. What we want to know is that our service has had a clinical impact. If you can measure the patient outcomes associated with this service, bang for buck, that is just absolutely gold. PHN will be very happy to hear about that. And of course, your patients will be the ultimate beneficiaries of improved services and better health outcomes there as well. And communicate that with your team, right? Share the good news, also share the bad news. Make sure that you communicate that really freely so that everyone is in the know of what's happening there. And that is the mind map, I guess, in a snapshot. So it sort of brings us back to the overall view of what I've just been nattering on about for the last 50 minutes or so. I guess what I would also say at this point is that it's been my experience that sometimes really great ideas can absolutely see resistance at the practice level from some stakeholders who don't want to think about or innovate in the way that some of these ideas have come forward. So that's possibly something else that you might need to think about. How will our new idea kind of land with the broader team? Can we predict where there could be some roadblocks and some barriers in the way? And before we start communicating this, is there anything we can do to lower those barriers to innovation and service delivery? So I think that's possibly enough for me for a bit. I really do want to take a pause and a breath at this stage. Does anybody have any questions or comments or insights or stories that they'd love to share after, what I've just, I guess, reviewed? So open up your microphones, turn on your cameras if you can, There's still many people that I can't see in the room, which is a bit disconcerting. But let me know what you're thinking, what's been helpful out of this. And Susanna's just rocked up. So thank you, Susanna, for coming to join us. Do you want to come join the conversation? What are you thinking? What's been helpful out of this for you? And just turn your microphone on too, please.
Finally. I was on the wrong screen looking at everybody's faces. Yeah, so it was good to hear what kind of things, well, especially the examples, what kind of things other people are doing. And I'm just attending from an urgent care clinic, so not all of this is for us, but lots to digest, I guess.
Yeah, look, I think this is true. Although I guess, Susanna, for you, in terms of an urgent care clinic setup, what you might be thinking about is the triage process and how your nurses would be involved right from the beginning to streamline the care given. I know that there are rules and regulations around how the service must be provided in terms of the funding that they've received. So what you're explaining there is that what you're thinking and where you're working has its own particular needs and guidelines and requirements, and that's absolutely fine. I want you to just come back to the ideas rather than the didactic steps to go, this bit applies to us, but that bit doesn't. We're not going to charge gap fees because we can't charge gap fees. That's a limitation for an urgent care clinic, for example. But you might still be able to say, well, our nurses can do more in terms of, the immediacy of the triage and identifying what do you need and, how urgently do I need to get you into the GP so that we can prioritise well, especially if the service is really, really busy. That could still be a way of streamlining and developing capability and, and service capacity that is entirely relevant to that space. Does that make sense?
Yes, absolutely. And I'm working in a space where we've just had a GP starting, where we didn't have a GP before. And we got lots of space, and we're quite busy. So we have several new nurses starting. So it's a rapidly expanding service. So lots to think about. There is a lot of ideas up in the air. So this is very helpful from that point of view as well.
Great. I'd love to ask if you're happy to share, what are some of the ideas that are coming out from the team that you've experienced to date?
Well, we have talked about or that has been brought up, the LGBTQI space. I'm not sure whether it's a nurse-led clinic, but all these ideas are up in the air. So we're just trying to sort of put brakes for a little bit to stabilise the service, as it has grown very quickly in the last 9 months. But yeah, it's lots of ideas are up in the air.
It's tricky, isn't it?
Yeah.
And look, this is the reason, I guess, that we're talking about it, because none of this is straightforward. All of this invites a degree of clinical risk, and we need to be really careful about how we roll that out and what's the resourcing that we've got, and has everybody got the skills that we need in order to do that well. They're big questions. Sort of throwing them out really quickly, but each one of them requires kind of pausing and going, whoa, what does that mean for us, and how can we do this? But of course, we also know that, especially at the moment, nurses by and large are not working to the top of their scope of practice. They can do more. They've got great clinical ability. We are constrained very much by the Medicare benefit schedule and the way that currently works. But I think those things are going to be changing. And I guess that's also why I am kind of being a little bit provocative and sort of throwing out there to say, well, yes, there is the Medicare benefit schedule. And for you in an urgent care clinic, you are absolutely beholden to it. You can't really move away from that. But for others, you possibly could. And by doing that, it will continue to develop nursing skill and capability and confidence so that when Medicare eventually catches up, we have a better capacity to respond to that in whatever way is going to be appropriate when the current barriers are lowered a bit, which, and, fingers crossed, we hope that, that will be happening. Okay, anybody else? Any other thoughts or questions or comments?
Can I just ask, does PHN have I guess, a list of examples of what other clinics have done and the models that they've used and clinics that have successfully run nurse-led clinics? Like, do you have I don't know, I guess a list of things that we could use as an example?
Well, thank you for your question. I honestly don't know if we do have such a list. I can always ask and see if we can provide anything. You would like to?
Can I provide some feedback there, Julio?
Yeah, absolutely.
APNA have an entire section on their website on ideas around nurse-led clinics. So go to APNA and you'll be able to read quite detailed case studies of what other practices have done and how they've gone about it. So there is a fair bit of information out there through APNA.
Okay, great.
Well, either way, I'll try to see if there's any particular example in our region, and we can send that out and see if there's such resource exists. Yeah, I think Annie has a question.
Yes, Annie.
Yeah, hello. I've got my video back, I think.
Yes, we can hear.
So I'm doing a postgrad course with UQ at the moment, and we did an imaginary project for, so each person has selected a imaginary or virtual one. So the ones I picked, I already handed in the assignment, but the assignment was for project management plan for implementation for wearable devices used for Holter monitor, because we currently is using one of those how would you say, a portable type of Holter monitor device. So my problem statement at the time was because the regional and remote area are really underserved in terms of their cardiac care, and even though, like, if you go further away from major cities, the services available for Holter monitoring, even for that one particular one, will become less accessible for people in those regions. And I guess sometimes when people experiencing some heart problems, they're less likely to investigate because of the inconvenience. But with the portable Holter monitor, usually the nurses or the GPs can put it on very easily compared to the previous older version of the Holter monitor, and it's less restrictive and it's really more easy to wear, and it doesn't really occur upfront fee for the patient because some of them provide a telehealth service as a bulk billing specialist service. So what is your idea or like from your perspective in terms of like rolling this kind of project out in, for example, in imaginary PHN in Australia?
Is the question to Julio?
Yeah, sorry, because this type of for a project design, there are like things we need to consider. But in terms of, I know that for this kind of service, there's an item number behind it. But if we're interested in something similar but doesn't have an item number both for the doctors or the specialist, is there any way to motivate people to get on board of this kind of quality improvement?
It is a difficult question, but I'm happy to have a discussion because I might not be the best person to ask, but I can definitely link you up with someone who might have a better answer than I do.
Yeah, so
if you're happy to, I'll put my email on the chat. this also goes for everyone. If you would like to, if you have any questions, please reach out. But
Yep.
I'll put my email and we can follow up with that question if that's okay.
Okay.
And look, I guess I would bring it right back to just the thinking points that we've just sort of outlined. So if the question becomes, how could we sort of roll out that kind of model of care? I love the idea of sort of remote monitoring, and I think, very clearly your idea has significant benefit, especially for rural and more remote patients. So it has inherently, like, it sounds like a great idea. And the question is, what would be the steps involved in seeing that to fruition? Where are the barriers? So I would, again, I guess I would remain within the practice to throw those questions around. How could we make this work? We know that there are barriers, but what could we do rather than what can't we do to bring this out? And of course, there will be financial constraints if there is no sort of Medicare item associated with it. But like I said, it may not mean that patients wouldn't be prepared to self-fund some of this. If the benefit is really tangible, then, the funding may come from patients directly, as much as that often feels really counter and very sort of anti-ethos in terms of, healthcare provision. It is a question that can be asked to say, well, is there a cohort of patients who would be prepared to sort of self-fund that? Of course, there could be conversations with PHN to say, here's a great idea. Is that something that the Commonwealth or PHN would have an appetite to consider further as well? These are all part of that whole conversation of ideating and what would the model look like and where are those opportunities? So I think you're asking, great questions, Annie.
Yeah, thank you. And I think it also created a downstream problem for the local HHS, because that will increase the patient number for maybe outpatient services.
Yeah, exactly. All right. Look, I'm aware that we are starting to run over time, and I want to not hold you up too long because I know you've got really busy lives. So if you need to go, please remember to fill out the evaluation at the end. Otherwise, we will, I guess, see you again. And again, if anybody does want to hang back with any other burning questions, I'm happy to hang around for a few more minutes for a conversation if that's helpful. Otherwise, thank you for coming along. I really appreciate it.
Thank you, everyone. And on behalf of the PHN, thank you, Rivka, for facilitating the session. Everyone else is welcome to reach out to the PHN. We have our practice support email. You have my personal email too. So if there's any questions, please reach out. We have a wonderful team of engagement officers who can guide you in some parts of this process. We can help you in analyzing your data and understanding your data and some other parts of this entire process. So please feel free to reach out. Thank you for coming. Help us with the survey. That really does help improve the quality of our training sessions and also to tailor our topics to the needs of the community. So if there's no any other questions, I do see that there's some people saying goodbye in the chat. Thank you, everyone. But if there's no any other questions, I'm happy to close the session. Yeah.
Fantastic.
Well,
All
thank you,
right.
everyone.
See you
And
next
in the
time.
following couple of weeks, you'll be receiving the recording and the resources. Just bear with us. It might take up to 2 weeks. Okay. And thank you, everyone. And I'll see you next time.
Terrific. Bye-bye.